Thank you, Mr. Chairman. It is a great pleasure and privilege for me to be here and to present my experience on the role of navigation in cervical pedicle screws. And I must say it is very sad not to be able to see the faces of the friends and colleagues from all around the UK. When I discuss about the benefits of technology, I really like this slide where I compare a spinal surgeon to a samurai. With years of training and numerous fights, we can become very skillful, we can learn to do amazing things with just simplest instruments. However, to get to this level of samurai, we have to go through different stages of learning, which often last years. And before we become samurai, we were all beginners. We had no or very limited experience, and we were much more likely to make costly mistakes, which could be incapacitating for our patients. And second point, even if we can learn to do amazing things with the minimal set of instruments, I strongly believe that if we were to give this samurai the support of technology, he could be much more efficient in whatever he was doing. In the next few minutes, I will try to demonstrate that navigation provides much higher accuracy comparing to non-navigated techniques, that it provides additional layer of safety for the patient but also for the surgeon. Navigation can enable safe training of young spinal surgeons, and very few words about the benefits of the navigation in routine and in slightly more complex cases. The technique of the cervical pedicle insertion has been well described. You could see it in the previous slides, and those of you who are AO Spine members may recognize this from the AO website, where each step is described in a very fine detail. By the way, if somebody is still not a member of AO Spine, I would cordially welcome you to join, and without doubt you will discover numerous other amazing things. So why we don't use this technique, this amazing technique, routinely? Obviously because of the risks. Unlike lumbar spine, which can be quite forgiving, C-spine has numerous critical structures, and if the screw is only few millimeters or few degrees away from the optimal trajectory, it can easily cause an injury to some of these structures, which can be quite catastrophic, I must say. And why this is happening? Because we as spinal surgeons, we can usually see only the tip of the iceberg. We can see the surface anatomy, but what we don't see what is underneath the bone. We don't see the spinal cord sometimes, we don't see the vertebral artery, the nerve roots. And although we would like to believe that all the vertebrae are exactly the same in every patient, the reality is different. We all know that there are potential significant variations. On top of this, we may have congenital anatomical abnormalities. The anatomy can be destroyed or affected by the tumors or trauma. Of course, X-ray can help, and it can show us what is underneath of the exposed surface of the spine. But the problem is that we don't often have this kind of X-ray. The reality is quite different frequently. Sometimes we can see only the top part of the C-spine. The AP X-ray may not be possible if you don't have a dedicated table to accommodate this. And we don't have the axial images, which could be quite helpful. Now, there are many options to stabilize the spine, but there are equally many options to fail this, despite our best efforts to avoid this. And this is a couple of patients which came to our units with the screws in places which we would like to avoid. You can recognize the screw in the vertebral artery. Another screw is very short, which is likely to fail biomechanically. Another screw is in the foramina, and the other one is in the spinal canal. To help to reduce the risk of these unpleasant situations, the navigation was proposed. And what is navigation? This is a 3D computer-based surgical technology which is designed to improve the intraoperative orientation to the unexposed anatomy, and obviously to help us to reduce the risk of iatrogenic injury. And when we operate with navigation, what we need to do is to merge the patient, which is fixed on the operating table, with the imaging which either was obtained preoperatively or intraoperatively, as we can see on this video, using the 3D X-ray or CT scan. Now, is navigation really more accurate? And I must say that over the years, the number of publications about navigation in spine has exploded. 4 years ago, when I was giving a similar talk, we already had more than 600 publications. These have increased over the years. Last month, we already had more than 1,100, and in the last month only, there were another 50 publications on this topic. Unfortunately, we don't have time to discuss and go through all these publications, which are quite interesting. But if you kind of screen these publications, you can see that there is a reasonable difference when navigation was used comparing to non-navigated surgeries. Now, let's look briefly on the impact of navigation on training. And one of the commonest comments I hear is that if the trainee will rely only on navigation, they will lose the ability of critical judgment and may run into trouble when navigation is not available or when it fails. I presume a lot will depend on the way the surgeon is trained. In my unit, what I really like is to ask the surgeon, the trainee, to expose the spine without looking at navigation and with the pointer to show me with where exactly, in his opinion or her opinion, is the entry point for the pedicle screw and what would be the optimal trajectory. And once they showed me this entry point and trajectory, I will allow them to look on the screen and they will immediately learn. If it is in a good position, this will reinforce their knowledge. If it is suboptimal, they can readjust their landmarks and learn it without causing any harm to the patient. And once they learn to do this in a standard pedicle screws, in the thoracic spine, for example, as we can see, we can do the same in the cervical spine, where it is more challenging with less obvious landmarks. And what is also important is that the trainees learn this quickly within few weeks, bypassing the months of or even years of the learning curve. And this paper compared the accuracy of screw insertion in a very junior trainee using navigation versus experienced spinal surgeons. So 300 screws have been placed by trainees and 300 screws were placed by the spinal surgeon, and as you can see, there is no difference. This is exactly the same accuracy between somebody who never did this before and somebody who was doing this for many years. So the trainee with navigation is as safe as an experienced spinal surgeon if we discuss about the accuracy of screw placement. I really wish we had some more time to discuss about the benefits of navigation in less complex cases, but we'll just have to fly over them. Sometimes the situation is complicated by abnormal anatomy. This is one of such patients with significant deformity of the spine and very severe spinal cord compression at C1, C2 level, and pay attention to the trajectory of all the vessels at the level of the spine. The 3D CT scan will show that all the standard anatomical landmarks for screw insertion, they're just missing. And this is exactly the case when navigation is particularly helpful. Your anatomical knowledge in this case is probably of no benefit. The X-ray would be of no benefit. And with navigation, we can identify the pedicles which are feasible for cannulation. And then during the surgery, we can just reproduce this trajectory which we could pre-plan day in advance. And the postoperative scan will show that all the screws are in a good position and we achieved our goal of decompression of the spinal cord and stability of the spine. Now let's look at slightly more complex cases, and I do really find navigation particularly helpful in the surgery of the tumors. This is one of such patients which has a large what looks like neurofibroma, compressing the spinal cord, but also encasing the vertebral artery which is located anteriorly. And the X-ray shows that there is already a degree of kyphotic deformity in the upper C-spine, so laminectomy is likely to make things worse. And now if we do the CT scan, you can see that the bone is eroded and there is not much bone left to accommodate the screws. And to make life even more complicated, the angio-CT scan show that there is an aneurysm of vertebral artery as well as some looping at C5 level, which will make things challenging when we plan to insert a screw at that level. First step, we had to stabilize the spine, so we were able to identify some of the pedicles feasible for screw insertion. Second, after laminectomy, we do the tumor debulking, and the first part of debulking we can do quite rapidly because we know that we're away from the vertebral artery. But when the navigation shows that we are getting close to the vertebral artery, we can slow down and do microdissection under the microscope until the tumor is removed completely. And in the end, we'll achieve our goal. The tumor is removed, the spinal cord is decompressed, and the stability of the spine is not compromised. To summarize, the navigation has multiple benefits. First of all, it brings improved accuracy of our surgery. It is a very safe teaching tool for our trainees. It is really helpful when we have deviations from the normal anatomy, high-risk areas. It certainly reduce the stress level. It saves our coronary arteries. It clearly helps to reduce the radiation exposure for you and for the surgical team. It helps to reduce the time of surgery, and it clearly can reduce the complication rate and the rate of revisional surgery. And what is more important, it makes more complex surgery possible in a wider surgical community. Now, coming back to the initial slide, we are all at some point will eventually learn to do fantastic and very difficult surgeries with minimum sets of instruments, but technology can help us to be much safer and much more efficient with what we are doing. The take-home message: navigation is a technology that was designed to help us to do our job better and safer for the patient and the surgeon. A tool is, however, no better than the hand that holds it. Yeah, fool with the tool is still a fool. This is something which we'll need to remember. We need to learn our anatomy first, and use navigation only to be better, not to replace our knowledge. Thank you very much.